Hi, good morning. So I'll be talking about economic study. It's an economic study, and as the picture shows, everything which is of use in healthcare has an economic weightage to it. So this is a scenario which will come to. It's not a patient scenario. This is a boardroom where there are people discussing. So there's a board members in the hospital discussing how to treat a patient who's come to the emergency department and to prevent venous thromboembolism. So that's the main aim of this board discussion. So they saw that patients who came with a trauma or under orthopedics got low molecular weight heparin, but patients who came with surgery or had an acute severe medical illness, they actually only got normal unfractionated heparin. So one of the board members did a appraisal, went to the PROTECT trial, found that there was no difference between heparin and low molecular weight heparin, and the board decided that because the cost of acquisition of low molecular weight heparin is more, so and heparin is as efficacious as this, continue using normal unfractionated heparin. So the person who presented it was wondering, is it actually just an acquisition cost, or is there so much more than just that and the cost effectiveness? And that is what we'll try to answer today. So the study is called eProtect. It is looking at the cost effectiveness of dalteparin versus unfractionated heparin in the prevention of venous thromboembolism to patients who come to a critical care setting. So I'll go through multiple few terms in health economics as we go along to the presentation. I will put everything in the beginning, so I'll go through and then I'll present what that means. So just the first thing before we start the presentation is, are the results valid? It's very important. So the four main questions is, did the investigators adopt a sufficiently broad viewpoint? Are the results reported separately for the relevant patient groups? Were the costs measured accurately? And did investigators consider the timing of cost and outcome? So now what is cost? I mean, English cost is money. So it's basically just that. Costing is the process of cost estimation, and this process is very important. And secondly, when you look at the viewpoint, a patient's viewpoint of a cost might be different from the insurance, from the healthcare giver's viewpoint, which might be fully different from the societal viewpoint. So that is the viewpoint of this costing. An example, now costing has direct and indirect. In direct, which is direct healthcare, that's what we see. We ask them to come for a surgery, there's a procedural cost, the medications, the doctor's fees, and the lab testing, post-op hemoglobin if you're monitoring. Now the indirect, the direct non-healthcare is now the patient has to come from A to B, the transportation cost. They're staying there. So that is a direct non-medical cost. Now what are the indirect costs? So because the patient has gone for a surgery, he's not been, he's out of work for 10 days. So those 10 days wages are lost. So that is an example of indirect cost because of this. So that's how we divide costs into. So now we'll go to the investigators. So this is the article. The article is a prospectively done randomized controlled trial looking at unfractionated versus low molecular weight heparin. So at the same time they've done an economic study which is looking at the costs. So now do the investigators adopt a sufficiently broad viewpoint? And the answer is no. So a broad viewpoint is like a societal study, but this is an in-hospital. I highlighted the word separately. It's an in-hospital healthcare payer perspective. That is what they. That is a viewpoint for the study. And the time horizon, if you look at it, is only from the period of randomization till the hospital discharge or death. So for usually health economic studies are long-term studies. They try to use terms like QALY, which is a more standardized term. So surgical patient and medical patient, they all have QALY, and they can use a health utility, cost utility analysis and finally come to a conclusion. But this is a very short-term follow-up, so we can't really use terms like QALY. So that is the one thing I wanted to highlight regarding the time horizon. So now are the results reported separately for the relevant patient subgroups? Now, why is this important? We're looking at overall cost, and the cost for a direct medical cost are multiple things: duration of hospital stay, anticoagulation use, any complications. So definitely a medical and surgical patient will have different overall costs. So that's what they tried looking at the important subgroups which will affect the patient in ICU and the total cost. And so they compare between different subgroups. So these are parameters which they feel will affect the incidence of venous thromboembolism, and the prevention by the heparin might play a role. So if you look at it, they have analyzed a medical and surgical subgroup. They look at Apache's 2 score, which is looking at the severity of illness. So definitely patients come in more severe, that's more than 25 is a cutoff, versus patients come in less severe, the overall cost of treatment will vary. Then the BMI, and then inotropes of vasopressors at admission. One thing when I was going through the trial protocol was they actually planned to look at patients who had ventilation invasive versus those who didn't. But finally, when they actually analyzed the subgroups, it wasn't there. So that was one limitations. But otherwise, it was divided in patient subgroups. So, like I said, this is to look at prognostic differences and which will overall vary in the costs of overall treatment. The next question is, were costs measured accurately? So I'd like to mention that the study again was an in-hospital healthcare payer perspective. So the answer for this question is yes. There are three dimensions of this question, but this study only looks at direct hospital healthcare costs. It does not look at indirect and does not look at direct non-medical. So that is because of how the study was designed, but the costs were measured accurately. So one thing in costing is, have they developed a list of costs that are required? Before I come to this study, I'll just say for an example, if a patient requires a hernia repair surgery, he'll require the cost of surgery, the cost of the healthcare profession, the cost of the mesh, the cost of investigations that are done. There are multiple parameters that are looked at. Similarly, how would the person doing the study know which are parameters to analyze and the funds for that to be calculated? So they've actually done their own systematic review where they looked at thromboprophylaxis in venous thromboembolism and seen what are the risk factors noted from that systematic review, and that is what they've taken as the parameters for analysis. And after doing this, they've done a pilot study to see feasibility in collecting this data. So that was quite well done, I thought. The next thing is, are the physical quantities of the resources consumed mentioned? So this will look at reproducibility. Well, if we mention the physical, like for example, so this is if you look at the using heparin, that's the amount of heparin used, or using if they had HIT, using warfarin, or using other non-heparin anticoagulation. But if you look for venous thromboembolism, these are the scans used. These were the ICU charges for the professionals, the ward, the number of hospital days. So even if our currency is fully different, our cost is fully different, we can actually use this data and come to our in-hospital setting, how much it would come to. So this is very important. Most studies should have this, and this study has it. The next parameter is valuation. So this is also an important term. So how are the costs collected? Are they assumed? Or so in this study, it was a prospectively done study. So actually the costs were collected directly from the hospitals. In places where it was not collected directly, they got the charges. It is not always that the hospital charge for a test and finding what the patient pays. So there is something called cost to charge estimate, which the institution will provide. And so patient costs were not collected directly. They done a cost to charge estimate and got the final cost. And finally, they've taken median values to assess cost. So this is a table of all the costs of each unit. Like a day one of critical care physician is this much, day one of the ward stay is this much, the cost of one vial of unfractionated is $3, whereas the cost of low molecular weight heparin is 8. So they've given costing which they've done. So now the next question, did the investigators consider the timing of cost and outcome? So like I said, this was a prospectively done RCT done over 2006 to 2010. The cost of 2006 treatment will definitely vary 2010 even if it's the exact same treatment. So have they taken that into account? That is what this question is trying to answer. And if you look at it, they've accounted for annual inflation and they have reflected the end of trial cost. So the answer for this question is yes. So finally, are the results valid? The study was not from a broad viewpoint, but apart from that, the subgroups were taken separately, the costs were measured very accurately, and the investigators considered the timing of costs and outcomes. The answers for all these are yes. So, seeing that it is quite a valid study, go on to the results. So, I'll be covering these questions, incremental cost and effect of each strategy, the different between group difference, and finally this term called uncertainty, whether the study allows for uncertainty. So before that, I just come to the terminology which I will go through and then come back to the results. So if you don't answer, you can ask. I'll try to explain to the best of my ability. So one is three main terminologies: cost effectiveness, cost utility, cost benefit, and then the ISR and the willingness to pay threshold. All these are very important terms. The first one is called the cost effective analysis. So here, like the word says, the cost of intervention to the effectiveness. What is effectiveness here? It is a clinical measure or life years. That is what they have taken the analysis of cost to. I took two examples. So there are two drugs for blood pressure control, amlodipine and cilnidipine. Amlodipine is 2 rupees and it reduces blood pressure by 2 millimeters of mercury. whereas Cilindipine is 10 rupees, and that's the cost, and reduces blood pressure by 10 millimeters of mercury. These are clinical measures. Similarly, PCI in heart in ACS will they can measure that as life lost. So it depends on what the clinical outcome they are measuring is. And this is called CE plane. Just want to highlight this. So figure 1 is a reference standard. This is X and Y axis. X axis shows utility. As you go positive means it's more useful, and Y axis shows cost. The positive is costlier and negative Y axis is cheaper. So this is cheaper, this is costlier. So if you look at this, I will tell you the first one. So figure 2, there's a point, you can see a yellow point there. So there's a yellow point here. So if you can look at it, it says the intervention is costlier because it's positive y-axis, but it's also more useful. Now, figure 3. Does someone want to try what that signifies?
It's cheaper and not effective.
No. So it is, yeah, it is cheaper, and compared to the other one, it's not as effective. That's correct. And this one, would you want to try it? Figure 4. Anyone? Cheaper and more useful. So this is the best case scenario where the intervention is actually cheaper and more useful. So now the next thing is the cost utility. So similarly, like this is looking at the cost and not compared to clinical outcomes like blood pressure or lives years. It looks at quality, which is the quality adjusted life years. So what it is without intervention, how the person is. If one is normally full health, no problems, and as you grow older you might have a slightly reduced quality, but let's say a person has a heart attack, he'll suddenly have a significant reduction in his quality of life, and that is what quality is. But he might still be alive. So from a score of 1, it might be reduced to 0.4, 0.5 because of this new disease. So a person who doesn't have a heart attack and a person who has a heart attack, even if they're both alive for 1 year, the quality of life in a heart attack person is 0.5, as a normal person is 1. So that's the usefulness of quality, not just quantifying life number of years, but more so looking at number of years and the quality of life he has in that year. So A is without an intervention, B is with the intervention. You would see that number of life years it has increased, and along with that there is a reduction in quality is there, but compared to when you do B minus A, that's when you get the differential quality. So for an example, amlodipine, which is 2 rupees, previously in the cost effective analysis we saw reduce the BP by 2 millimeters mercury, and it is assuming that finally at the end of starting amlodipine and that 2 millimeter of reduction of blood pressure might actually cause a quality of 1 year gain. Whereas cilindipine, which causes a 10 mm reduction in mercury, when you look at the quality, you have 2 qualities gain. So this is how you represent a cost utility analysis. Now cost benefit analysis is the best when you actually look at finding what the monetary outcome of doing all this is. So a person who's had a reduction of 10 millimeters of mercury of blood pressure, what is the overall cost he's gained in life? Has he gained 1 lakh rupees, or has he gained 50,000 rupees? When someone compared to amlodipine, because of not such a significant blood pressure decrease, has probably more side effects. So he might have developed heart disease earlier. So that's how you find the overall cost benefit analysis. So now we come to ICER. So what is ICER? So this is after we get the analysis, so either cost effective, cost utility, or cost benefit, we need to see how useful it is. And this is when we look at the incremental cost effectiveness ratio. So this is looking at the cost of A minus cost of B by effectiveness of A minus effectiveness of B. So this is ICER with cost utility scores. I've taken that because quality is a generalized score for most diseases. So calcium, the cost of cilindipine minus the cost of amlodipine is 10 minus 2, which is 8. The quality from cilindipine gave 2, the quality which amlodipine gave is only 1. So if you look at this, it's 10 minus 2 by 2 minus 1, which is rupees 8 per quality of life gain. So it's a very, so that's an example of what ICER shows. So I will come to willingness to pay in the next slide. Just one thing before coming to that is, so if an ICER is less than 0, it means either the numerator or the denominator is negative. That means either the cost of the intervention is cheaper, or the effectiveness of the intervention is less. I mean, one of the values are negative. So when you have this, it's a clear indication that A or B, that either A or B is obviously dominant. So you would not need it on ICER. ICER is done when it is either costlier and better, or cheaper and worse, and to see is it better than the control. That is what ICER is used to. But when either A or B is clearly better, so A is cheaper but superior, or B is costlier and worse, then definitely you would not need to do an ICER. So I just wanted to mention that for utility using ICER. So finally, the willingness to pay. So in this example, which I shows just 8 rupees to stay in one colony, but there are.
Can you just repeat what you just said about when not to use ICER?
So ICER, so if the drug is in CE plane, the new intervention, it means cilnidipine is better than amlodipine, but it is also costlier. So that's when the question comes: should we give it or not? Because if it's so costly, which is mild benefit, would not want to give it. Whereas only marginally costly, with a lot of benefit, would want to give it. So that is what. So to calculate, see how much more benefit it is, we use the term ICER, which will give us a value. So if it is, for example, you are doing intervention like PCA versus CABG, and PCA, to get one quality of life, the amount is 1 million. So then it's not, then it depends on the country's economics and how much they want to invest in doing that. So that is to calculate the scoring ICER to get to know how benefit it is, how much of a more benefit and economically viable option it is compared to the control.
So you're saying if it's like something like figure 4, you don't need it.
So if it's figure 4 or the dot is here, you would not need it. Because figure 4 obviously is better than the previous one, so you would want to do it. And figure this one is obviously worse, it's costlier and less utility, so there's no point in the ICER. The ICER is when it lies between in these two boxes, so there will be a line like this, and you want to see where it goes about, and that's how you use the ICER. So ICER is only for these two indications. And if the value falls here or here, the ICER will become negative, and then so that just signifies that there's no need to do an ICER. That one is definitely superior to the other. Willingness to pay, like I said, was, so if the PCA versus CABG was 1 million for one quality of years, should the government invest in it? So WHO made a cutoff saying if the ICER is less than 3 into the GDP per capita per Delhi, it is an economically viable option to consider. Whereas if it is not, it is then it is not for a societal perspective. So I just wanted to mention that, because willingness to pay, at the end of it, everything is willingness to pay, the trade-off between health versus economic benefit, economic use. So knowing these terms, we'll come to what the study looks at. So this is what are the incremental costs and effects of each strategy. So I'll come to each of these points. The first one looks at total cost incremental difference. So this is, if you look at all the units of dalteparin used in all the patients, and all the cost per unit, one can say multiplied and get the value. And at the same time, they do the same for the cost analysis and the amount of product used. They do that for heparin. The total difference, what they see is the total cost incremental difference. Now they calculate the next point, the cost per patient. That is, after calculating the total cost by number of patients, they get the total cost per patient for heparin and dalteparin. Once they subtract dalteparin with heparin, they found dalteparin being cheaper. The low molecular weight heparin was minus 1297, the median difference. Not the mean was minus 1490. So that shows the intervention is cheaper. Now the next point, is it better or worse? So this is the RCT which they were doing. This is the economic analysis of the RCT. So the effect is got from the RCT. In the RCT, all groups favored dalteparin. If you look at it, the venous thromboembolism prevention, the hazard ratio is 0.89. With 95% confidence interval, 0.79 to 1.01. So this tends to favor dalteparin more than heparin, and with the effect that dalteparin is cheaper than heparin. So then finally, which part of the box will this fall in? This will be in the figure 4 which we saw, cheaper but better. So this actually would not require an ICER evaluation at the end. So finally, dalteparin is a dominant strategy, and that's why they have not done an ICER in this study. Now, do the incremental costs and effects differ between subgroups? So, like I said, they did a subgroup analysis which was well done, except they didn't look at ventilator days. And if you look at it, 7 out of 8 show dalteparin is better than fraction heparin. And even if you look at the subgroup, so it makes sense also. The partial score less than 25 and more than 25. Obviously, sicker patients who come to ICU will have a costly hospital stay, and that is showing overall outcomes of dalteparin being more than fraction heparin. So if you look at minus 4,364 to minus 107. So apart from this baseline vasopressors patient not requiring, which tend to show unfractionated heparin might have been overall more cost effective. The others all show that low molecular weight heparin is more cost effective. And the last thing is how much does allowance for uncertainty change the result. This is as important as the overall result which we got as of now, showing low molecular weight apparent is better than unfractional apparent. So now I'll talk about these three terms and then come to what the study's result is. So one is uncertainty, sensitivity analysis, and the types of sensitivity analysis. So uncertainty. So this just means how certain are we of the results. So most studies look at parametric uncertainty, and that's what they analyze with the sensitivity analysis. So the first one mentioned here is called the stochastic uncertainty. So here what it is a variables that happen by chance. If, for example, individuals are at risk for influenza after exposure of 20%, does not mean everyone is at 20%. Some might be more, some might be less, and even between two identical patients in height, weight, gender, everything. So the fact that these things happen by chance is called the stochastic uncertainty. Now the parametric uncertainty is if my cost of hospital stay in ICU for 1 day is 2,000 rupees in CMC, doesn't mean Narayani or Narayani or any other hospital going to be the same 2,000. So does this 2,000 which I have done for the study, is it going to be same? It's not going to be the same everywhere. So if these values differ, how will the outcome differ? That is what we look at when doing a sensitivity analysis. Structural uncertainty is a little more complicated, which is not really analyzed by the study. Is to see if the model they use to come to this conclusion is correct. So we are looking at breast cancer outcomes. Have they looked at all outcomes of breast cancer? Have they modeled it with time, and have they adequately done it for long enough to say that this much amount is required for the intervention in breast cancer? So modeling is a very important aspect in doing economic studies, and modeling can play a very big role. So that is what you look at with structural uncertainty. And heterogeneity is, yes, between patient groups by different baseline characteristics, they will differ in the outcomes. So sensitivity analysis, like I said, to look at parametric uncertainty is what we do. And so this is to not look at the robustness of the study, look at the robustness of the conclusion of the study. The study may be good, yet the sensitivity analysis might not show a robust study. So now, what is it in simple terms is, if I change the input and then keep doing analysis, will my ISER or my output will change, but is this change showing the same conclusion as the initial thing? So does it all, when you keep doing the study with different variable inputs, does it keep showing that unfractional apparent is inferior to low molecular weight apparent? So that is what we look at in the sensitivity analysis, and there are many types. So like I said, so there's the effect of the changes. What is the result of that, and is it a consistent finding with the primary analysis? And then if it is, then we think that the conclusions are robust. But if it is going on either side, yes, no, when you keep changing variables, if you change just the cost of hospital stay, if you change a personal cost, if you change the cost of the drug, if you change the conclusion, then it's not a robust conclusion. So the sensitivity analysis types, there are two things. One is a deterministic sensitivity analysis, one is a probabilistic sensitivity analysis. So the deterministic sensitivity analysis, when you look at when you look at a few variables, keeping everything else fixed. So there's one-way analysis, two-way, and multi-way. So just for an example, I didn't want to keep talking about attraction and low molecular weight. So imagine the two drugs, drug A, drug B, looking at HIV prevention by taking it. So after getting exposed to HIV, if I take drug A, my exposure to HIV is 90% prevention, whereas if I take drug B, it's only 50% prevention. So that, and then we calculate an ISER based on that. Now imagine drug A costs 10 rupees, and we do like the cost is 10 minus 5 for drug A, drug B, and the effectiveness is 90 and 50, so 0.9 minus 0.4, and you get a value. Now if the cost of drug A goes from 10 to 500, because the cost may vary, will the outcome be the same? So when you look at only one variable, it's called one-way analysis. Now if I have the same thing with two drugs, and now I'm not just adjusting one variable, so it's not just drug A's cost or drug B's cost. At the same time, while adjusting drug A and drug B's cost, you look at the prevention. So from 90%, what if it's 80%, or what if it's 85%? So when you analyze more than two variables at one time, it's called a two-way analysis, and then there's a multi-way analysis. One-way analysis is the best to look at which plays the most role in the overall outcome, and they do this with multiple methods of analysis, and they present it. So in this study, I'll show you how they presented the multiple one-way analysis. And the next thing is called the probabilistic sensitivity analysis. Here, it's not that just one variable is changed, all variables are changed according to the probability distribution of that variable. So just like, so this is what a probability distribution is. So the cost of drug might be a narrow, might not be much variation, but the cost of hospital stay might be a huge variation between hospital. So once you take a probability distribution for each variable and then you keep doing multiple analysis, that is done with Monte Carlo simulation, and you keep getting different ISOs, and then finally you plot it here and you get multiple dots. So that's what our study we have done. I'll come to what our studies, but this is the picture in our study. These are multiple ISOs, and this is showing the overall outcome. So that's how this picture actually came, which I showed initially, and that is done by a probabilistic sensitivity analysis. So finally, in our study, so how is this? How much does allowance for uncertainty change the results? So the first thing is, there's a sensitivity analysis done. Yes, it is done. It is a multiple one-way analysis. They've done the tornado diagram, and if you look at the tornado diagram, you can see that the most weightage and the contribution causing the difference between the two groups is by ICU resources per day and the personal cost. So these are how much each thing costs and the weightage of importance. So that is what is shown in this tornado diagram. The next thing is, if you look at, so they done multiple one-way analysis, and they found that everything except for when the cost of dalteparin was increased exponentially, when the cost of dalteparin in study was 8 was made more than 179, that was the only time when the treatment strategy by unfractionated heparin was costlier, was cheaper. Otherwise, for every other variable that was analyzed, which between both extremes of the probability curve, dalteparin is always a cheaper option. So only the cost of dalteparin per se increased to more than 179 was when the study conclusion was not met. So because it was only that one scenario, which is quite rare, because the cost of dalteparin being from 8 to 179 is a huge exponential increase, nearly 25 times. So that's why I concluded that the study had a robust result. And finally was the probabilistic sensitivity analysis, when by this they come to the final conclusion, and if you look at it, 78% of the simulation conclusions are all showing this, which is improvement with lesser cost. It's on the left side, which is against what we were initially discussing. That is because you're looking at prevention of thromboembolism. When it comes to the right side, that's rates of thromboembolism. So because this is a harm event, they've come to this side. So that is why it is showing benefit, less thromboembolism rates, and cheaper. And 78% of it lies in that. So that's how we come to the conclusion that low molecular weight was the dominant strategy. So now finally, how can I apply the results to my patient care? So the first question is, are the treatment benefits worth the harm and cost? The answer is yes. Dalteparin is a dominant strategy, meaning it was cheaper and showed a trend towards protection compared to unfractionated heparin. So that's why an ISO was not required. Normally for this question you would want to know the ISO and the willingness to pay scale. So is it more than the countries, more than GDP per unit per Delhi? But for this one it's not required. The second is, can I expect similar costs in my setting? I think the answer is no, that because the cost in India and the West are pretty different. But if you look at the parameters which they've actually analyzed which influence the cost, that is what we also have, the same ICU personnel, the drugs used, the lab parameters, the scans taken to diagnose thromboembolism, the same parameters used. So apart from the direct cost difference, it is otherwise similar to my patient setting. So finally, in the boardroom meeting, which was the discussion happening between unfractionated heparin, low molecular weight heparin, even though the acquisition cost of unfractionated heparin is cheaper, the overall cost suggests that it is better to use low molecular weight heparin because it is cheaper.